Hi class, you would have sat through Dr. Mitchell Lai's session on the different pharmacological classes that we use for hypertension, and we'll now be embarking on ELIN 6.1 on the selection of first-line, second-line therapies for essential hypertension with or without comorbidities. All right, by the end of these IC6 pre-sessions, learners should be able to discuss how first-line, second-line agents are selected for essential hypertension with or without the presence of comorbidities, and that's for EL1. In preparation for EL6, please review material from IC4 and IC5. Keep the antihypertensive drug formulary handy, the one which I uploaded into Luminous. Familiarize yourself with the antihypertensive formulary in respect to the usual drug names within each class, the classic adverse drug reactions, and contraindication profiles, as well as the usual dosing. This slide is a very important concept slide on how chronic blood pressure is maintained and the key role that the renin-angiotensin system, as well as the kidneys, play in the whole system of things. And Prof. Wee will have brought you through a version of this. Look at the left-hand side where there are 6 classes of pharmacological agents that are commonly used to modulate blood pressure. And Dr. Lai will have taken you through all 6 classes with respect to its pharmacology. Now look at where they are labeled in the particular diagram, and you will start to reason the mechanism of action and why certain agents are used in combinations with the rest and why certain agents are not used in combinations with the rest. This is the very basis upon which they will be talking about combination therapy for antihypertensives in the treatment of hypertension. I would like you to think further about the ACE and ARBs, how similar they are, how different they are, can they be used together, and whether they're used as an alternative to, or how they're used in clinical care. Secondly, think through the calcium channel blockers or the calcium antagonists, and these are both called the same things. With respect to hypertension, usually the dihydropyridine class of calcium channel blockers or calcium antagonists are used. The dihydropyridines comprise of amlodipine, felodipine, and nifedipine in Singapore. The non-dihydropyridines, with a different mechanism of action, are not commonly used for hypertension, though diltiazem can occasionally be seen. Think through how the mechanism of actions are with respect to the dihydropyridines and the non-dihydropyridines, and you would be able to reason out why certain drugs are used for blood pressure and certain drugs are not. Thirdly, think about the class of diuretics. Commonly used for hypertension is thiazide and thiazide-like diuretics, and not so much of the loop diuretics. Lastly, the class of the beta blockers have now dropped in favor. They are not commonly used as first-line agents until they are concomitant comorbidities, which we will explore later. The whole class of beta blockers are also very heterogeneous. I'm sure Dr. Mitchell Lai has also taken you through what are the very important features to think about when you're thinking about beta blockers in heart failure in the later themes of what we'll be covering through in the subsequent weeks. Lastly, the mineralocorticoid receptor antagonists, or some call aldosterone antagonists, are not used as the first line first choices for hypertension and are reserved as the second or the third line with respect to adding on when there's resistant hypertension. So with that, we'll proceed on to the subsequent concept slides. It has been confusing, right? Why different guidelines have used different grades of hypertension to call them hypertension and when to start treatment. For now, let's just assume that a diagnosis has been made and treatment has to be started. Let's explore further on the choice of first-line antihypertensives and combination therapies. On this particular American guidelines, they talk about the first-line agents as D, thiazides, C, calcium channel blockers, and A, ACE inhibitors or ARBs. Now, to highlight the Singaporean guidelines, they talk about the A, B, C, and D in their recommendations. And the Singaporean guidelines recommend beta blockers as well as first line, ranking both ACE and ARBs as equivalent. Now, beta blockers have long been dropped from the recommendations as first line, and I think maybe the Singapore guidelines was slightly behind in its recommendations. So I had intentionally put B in white and not so big in fonts, just to highlight to you that the first line agents that's used for hypertension should be A, C, and D. There. hypertensive therapies are as easy as A, B, C, and D. Now, I would like to also highlight the Singapore guidelines having that particular chart where there are arrows in that particular diagram over here. Now, the solid lines refer to highly effective combinations based on RCT evidence. And that means that you can use A plus C, C plus D, or A plus D as combination therapies whenever you need to add on or use two drugs to treat hypertension. The dotted lines refer to combinations that are less well studied, and that's C to B. And the combination of B and D has been frowned upon because there have been data that surround the new onset diabetes when you use beta blockers and diuretics together. The reason why beta blockers have been dropped as first-line therapies is also because most of the clinical trials that look at beta blockers for blood pressure lowering involved atenolol. And therefore, the evidence with beta blockers also is not as strong as the rest of the agents. With respect to the combination of beta blockers and diuretics, because it has been also frowned upon because of the increase in postulated insulin resistance and also associations with new onset diabetes, the beta blockers have dropped in favor. So the American guidelines also talk about use of two first-line agents if you ever need to use them in combinations. And they refer to stage 2 hypertension, and if you need to reduce blood pressure more than 20 millimeters mercury systolic or 10 milliliters mercury diastolic above the BP targets, you would want to start with two agents. And this is actually governed by the principle that one antihypertensive would drop your blood pressure by about 10 millimeters mercury systolic and 5 millimeters mercury diastolic. So this is a very key principle that all pharmacists and pharmacy students must know. Remember our friend Mr. Gao Shuyat? Well, we have advised him on smoking cessation and LDL reduction through modification in diet, and that can be followed by either A, C, or D. So how do we choose? Now, I just wanted to bring up a point that BP lowering effects on medications can differ from ethnic group to ethnic group. Look at this study that compared the African Americans versus the non-African Americans. And if you looked at how the ACE and beta blockers has its effects in these two groups of people, the non-African Americans seem to respond better to ACE and beta blockers. And this has been postulated to be due to the differences in renin levels or renin sensitivity with respect to the two ethnic groups. Now, looking at the calcium channel blockers and the thiazides, it appears that the African Americans seem to respond a little bit better than the non-African Americans. In fact, the non-dihydropyridines seem to be a bit more effective in African Americans than non-African Americans. Now, Asians are not as robustly studied, fortunately or unfortunately. What is known from population studies is that BP lowering effects are likely to be similar between classes, but disease outcomes seem to mismatch the degree of BP reduction. So a lot of the recommendations of what is considered first line when they're concomitant comorbidities are really based on randomized controlled trials that have shown benefits with respect to BP lowering and the associated classes. In general, the calcium channel blockers or calcium antagonists are more effective in Asians. And there seems to be more cough and angioedema when ACE inhibitors are used. Let's rehash on the choice of antihypertensives and the concepts behind it. So if you recall, there are pretty much 5 classes of agents that we can offer to all our patients. Of course, beta blockers are no longer first line, and therefore that leaves you with potentially 4 different classes, 2 A's, a C, and a D. Now, which one first and how many is really all about where you are and where you want to get to. Allow me to explain. If you are stage 1 hypertension, then you start with one agent because the intent is to reduce blood pressure by 10/5. However, if you're stage 2 and above and you want to really reduce blood pressure by more than 20/10 above the target blood pressure, then you would use a combination of 2 drugs. Further on, when we talk about targets, you would see a bit clearer what I'm trying to get at. So do not worry, I will not be testing you on which guidelines that you want to apply, but more the concept behind how many drugs will get you to the target that will be set for you in the questions if it was ever asked. Now, the other thing I wanted to stress is the importance of the pharmacist in person-centered care and shared decision-making. It is critically important as a pharmacist to offer all possible options, and in this case, we're talking about AA, C, and D. We should be very familiar with the pros and cons, the clinical profiles, side effect profiles, cost, follow-up, and monitoring implications. So it requires for you to know the characteristics of the classes very well. And also why we teach you to work up patients with respect to their background and concomitant conditions, because all those considerations will also factor into what you would finally offer to your patients. And today's patients are very well educated, so it's critically important for you to know what are the benefits and risks and what are the following counseling points that will come after, because the patient will always ask, is this safe? Is this going to be effective? How much is it going to be? You need to know all these information at the tips of your fingers. This chart is a very important overarching concept chart on the impact of compelling indications with respect to your choice of antihypertensives following people with these concomitant conditions or comorbidities. So we keep talking about ASCVD in the previous lectures, and these actually refer to the myocardial infarction, coronary artery disease, especially angina patients, and stroke victims. So these are people you commonly think of when you talk about ASCVD. So with respect to all these indications and comorbidities, the short way of describing this is that the ones in blue boxes are often agents that will be compellingly indicated in the various conditions anyway. For example, in a stroke prevention, if you needed to treat blood pressure, and as I mentioned earlier with respect to the earlier slide, the blood pressure lowering effect is not always correlated with the benefit of the drug in the various comorbidities. So in stroke, for example, thiazide-like diuretics as well as ACE inhibitors have been shown with positive comorbidities and mortality benefits in stroke, and therefore these two agents are considered first line with respect to choice of antihypertensives. In your subsequent weeks, you'll be covering atrial fibrillation as well as heart failure, and so I shall not belabor the point here nor give the thunder away. So the other groups that we talked about in the earlier lectures are diabetes mellitus and chronic kidney disease. Now, the staging of CKD you probably learned in this coming semester, so I will not talk about it at this time. But suffice to say, these two groups are very special because they are not quite ASCVD type patients, but they are also disease modifiers in terms of how you would decide whether how fast or your threshold with respect to starting antihypertensives, as well as the target blood pressure. Right, and because it's fairly common, I would like the class to remember that if you had these compelling indications with respect to diabetes or presence of chronic kidney disease, you probably want to use any first line, particularly for diabetes and for CKD. If you have concomitant proteinuria or albuminuria, you would want to use your RASI agents of ACE inhibitors or ARBs. Now, if there are other issues that the RASI agents will confer, then you probably go on to the choice of calcium channel blockers and following that diuretics. This other group, there are pregnant patients that I want people to remember, because where pregnancy is concerned, mothers are very sensitive about harming their babies. So it's critically important for us as pharmacists to remember what are agents that are suitable for pregnant patients, particularly when they have got high blood pressures and, if we learn later on, eclampsia. Now, these are the agents that I want you to remember because there aren't that many choices that we have with respect to pregnancy. Lastly, this group is not so common, the benign prostatic hyperplasia type of patients, or BPH, and this is commonly seen in elderly males who are more than 60 years old. In this group, alpha blockers are indicated, and therefore if someone has concomitant BPH, usually you would use alpha blockers as the first line therapies. Aside from that, because of the fact that there was this all-het randomized controlled trial that caused a very bad impression of alpha blockers are almost never used as first line in hypertension anymore. So going back to your principles, remember your A, C, and D, and sometimes B. So I want to call to your attention the black boxes, because those black boxes are really contraindications. And for these people, we're talking about heart failure, to remember not to use non-dihydropyridine CCBs. And this again goes back to the mechanism of action. Think about why. And also for pregnancies, do not use ACE inhibitors, ARBs, or direct renin inhibitors, because these agents are contraindicated and are associated with teratogenesis. So here's the strength of the Singapore guideline that I wanted to call out. And these tables list out the presence of compelling indications, pretty much saying the same things as what DiPiro says from the previous slide that I covered. Just calling out an example here on diabetes mellitus for your attention and noting. I also want to mention that there is these contraindications that they called out on the other half of this chart, which is not quite true. With respect to COPD, or chronic obstructive pulmonary disease, there has actually been newer studies to prove that beta-1 selective beta blockers, notably bisoprolol, in a cohort study has been associated with actually better outcomes if you continue them in well-controlled COPD patients. However, in reactive airways disease like asthma, because they are sometimes very reactive and not well controlled, then beta blockers are certainly contraindicated. And so be careful about the use of beta blockers in people with that background. For the CKD population, they also recommend the use of ACE or ARBs even in stage 5 or end-stage kidney failure, which I think is not so advisable, because the ACE or ARBs used in this group of population will be very associated, highly associated with hyperkalemia. So ACE and ARBs should not be used unless patients are already on dialysis with respect to stage 5 CKD. Let's move to monitoring and follow-up. So what to monitor when adding a new antihypertensive? This is quite a given comment, but of course you want to monitor for effectiveness, which is really the BP control. And don't forget to think about that whenever you start someone on blood pressure treatment. The other thing is adherence, and someone has said the medicines are only as good as those who swallow them. So it's critically important that you find out whether the patients are taking the medicines as is been prescribed. The last concept is really relevant adverse drug reactions. And this is a geeky point, and this is what I find so fascinating as a pharmacist, mainly because the ADRs are commonly an extension of the mechanism of action of the various classes of agents. So it makes it quite easy to remember, because if you remember how the mechanism of action is for the various drug classes, you should be able to remember the relevant ADRs, or at least for the most part, majority of the ADRs that you need to be monitoring for. So for the class of ACE inhibitors and ARBs, because they modulate the renal angiotensin system, right? So you would think about the modulation of potassium and essentially serum creatinine, because of the way that they act on the efferent and afferent arteriolar system in the glomerulus. So in 1 to 2 weeks time, it would be indicated for you to order a renal panel, or for those of you who want to save money, you can do serum creatinine and potassium alone. For those on ACE inhibitors, check for cough. This does not occur with ARBs. And the key point I want to stress here is the ADR cross-reactivity between ACE and ARBs. Now, for creatinine and for potassium, the cross-reactivity is often there. If someone has developed it to ACE, they are likely to also develop hyperkalemia as well as AKI to ARBs. And AKI sometimes is a function of dehydration as well. So you need to be exercising some sort of clinical reasoning and thinking about what could be attributed to the rise in serum creatinine. The other ADR that is commonly seen as a cross-reactivity reaction is really angioedema. And angioedema is potentially life-threatening. So please be very, very careful if someone has been labeled with an angioedema to ACE inhibitors. Although it is less likely to occur with ARBs, it can still occur and is known to be a cross-reactive issue with the two classes. So the only thing that does not serve any cross-reactivity is really cough. And so essentially, I think the only situation that you probably switch an ACE to ARB is when someone develops a cough to ACE. And this will become more relevant when we are talking about heart failure later on. For the class of beta blockers, we will want to call in about 2 to 4 weeks to check in PRN, because you don't really need to monitor blood tests for these agents. You also want to monitor pulse rate control. And the reason why I use pulse rate here is because for you to measure heart rate, you really need to be putting a stethoscope and literally counting the number of beats per minute at the apex of the heart when you listen to the chest wall. For calcium channel blockers, same, there's no need for blood tests. You can call in 2 to 4 weeks to check in on the blood pressure response. Again, if you're using non-dihydropyridines and because of the mechanism of action, think about monitoring the pulse rate as well. For diuretics, think about repeating the renal panel. And for some sensitive folks like the elderly, the sodium can actually drop quite precipitously. So for elderly, especially when it's the first time you're starting on a diuretic, you might need to order the full renal panel, which comprises of the sodium on top of the creatinine and potassium. Otherwise, for those who are younger and potentially you're not so worried about hyponatremia, you may want to just order creatinine and potassium in order to save money for our patients. Again, for these patients, you can call them back in 1 to 2 weeks' time. In a nutshell, monitor for effectiveness. Recall that one drug is probably able to confer about 10 over 5 millimeters mercury on systolic and diastolic pressure respectively. You want to monitor for adverse drug reactions, and when you think about ADRs, think about the mechanism of actions of the various agents, maybe with the exception of angioedema, which actually also related to the mechanism of action of ACE and ARBs. It's quite important to think about the ADRs in light of the MOAs. And sometimes the fact that the effectiveness is also interrelated with the ADRs is something that you can't really help. For example, for beta blockers, sometimes you really want it to also slow down the heart rate for certain circumstances. And then they become bradycardic is also something that's expected. So the key behind the whole method is really monitoring your patients when indicated in the timeframes that you should be calling them back for. We will compare the guideline recommendations on when to commence therapy and how to target blood pressure during the live interactive class. So with that, we will close here on monitoring and follow-up. In this final slide, I want to call out the causes of resistant hypertension or resistant in inverted commas in some scenarios like non-adherence and inadequate dosing. I think these are factors that you want to think about if the blood pressure doesn't quite respond to the first dose of the medications you've given or the first combination of the medications you've given. The more important thing is check to make sure that your patients have actually swallowed the medicines first before even making a decision on whether you want to adjust dose or change therapy. The other possible contributors are improper BP measurements. Sometimes fluid overload in a heart failure or CKD patient can be the reason why there's resistant hypertension. Some patients are salt sensitive and excessive sodium intake can cause very high blood pressures. I also have a patient from before who is a Karanguni patient, and I remember that he lived at the bottom of HDB flats, and his diet actually comprises of canned foods as well as instant noodles. And you can start to imagine instant noodles, the soup mixes actually contain a lot of sodium, be it in the form of salt or in the form of monosodium glutamate. So I just want to point out that for sodium intake, sometimes it's not quite obvious that food tastes salty, but can also contain sodium. Some other sources of sodium include soy sauce, which is not commonly seen in the US references. Sauces like ketchup and chili sauce are also fairly high in sodium because of the way that they put in preservatives. Also, the other source of mustard can also be a source of high sodium intake as well. So watch out for those potential sources for people who are sodium sensitive. Volume retention from kidney diseases is similar to volume overload. Sometimes inadequate diuretic therapy, which is also interrelated with volume overload, can be the cause of resistant hypertension. I recall what we talked about for secondary hypertension in the earlier sessions, and drug-induced causes could be also one of the reasons. People with obesity, excessive alcohol intake, and obstructive sleep apnea. Remember your lifestyle modifications and how obesity and alcohol can contribute to high blood pressure. And OSA, which has a mechanism of the disease state, which is one of the listed secondary causes of hypertension as well. With that, I'll see you in session 6.2.